Hello and welcome to our faculty development session. I'm Jennifer Hartmark-Hill, and I'm looking forward to sharing some highly valuable tools to help you become even more effective and time efficient as a clinical teacher. Our learning objectives for this session include to discuss options for teaching students in the clinical setting consistent with maintenance of patient care and productivity, to describe a variety of teaching methods that are both time efficient and effective for precepting students in a busy clinical setting, and to identify effective methods of communicating expectations, setting learning goals, and engaging in the feedback process with students. We'll accomplish those objectives by reviewing goals for teaching when time is limited. We'll explore a number of tools, which you may hear referred to as micro skills, and we'll share a few case demonstrations by way of practical examples. Finally, we'll consider some creative options for logistic planning in your work setting. To start with, let's review our goals for teaching in the clinical setting. With regard to effectiveness, we need to promote high learner retention. We need to see competency and performance improvement, and we hope that both teacher and learner enjoy the process. With regard to efficiency, the process needs to be feasible, patients must be satisfied with the care they're receiving, and of course we need an administrator and clinical team buy-in. With regard to approaches, specifically content, we're looking for high-quality, evidence-based, and patient-centered teaching that is tailored to the individual learner needs. Finally, with regard to logistics, we want to promote teaching methods that integrate with your patient care and other duties. Here's an inventory of the tools we will discuss. Having options and knowing the utility of each tool will help to provide a reliable framework to follow when we're teaching and providing patient care real time. We'll be spending most of our time on the 1-minute preceptor tool. If you only remember one of the tools from our session today, this is the multi-tool of the group. It is widely applicable across learner levels and types of knowledge and skills described by learning theory. The other tools include 2-minute observation, the Aunt-Mini model, the SNAPS model, the SPIT model, and activated demonstrations, which is related to bedside teaching. In addition, many of these tools have built-in feedback steps, making them quite efficient. Let's start with the 1-minute preceptor tool. This is used after a student or resident presents a patient to you. There are 5 components. The first step is to make sure that you get a commitment about what the learner believes is going on with the patient, whether in terms of a problem list, differential diagnosis, pathophysiologic process, etc. Learners who aren't held to a standard of stating what they think is most likely may not realize how much or little they know if the attending immediately takes over and shares their ideas. In the second step, the teacher probes for underlying reasoning or alternative explanations. This step ensures that the learner did not get the right answer for the wrong reason. Both steps 1 and 2 are ways to diagnose a learner, a very important approach taken by skilled educators. You can then teach a general principle that is tailored to the learner's needs. The time-saving step is that you only teach one brief concept. Studies show that learners don't retain more than a few pointers at a time. If you think that more in-depth knowledge on the topic is needed by a novice learner, you can always address in step 5. But first, after teaching a general principle, move to number 4, provide positive feedback for what the learner did right. This is essential to creating a safe and empowering learning environment, and will open up the learner to better hear and receive step 5, which is correct any errors by making suggestions for improvement. For example, you might say something like, there are some red flag or worry symptoms I ask all patients presenting with headaches, which are ... It's important to always ask patients this because next time I encourage you to remember to ask patients about these symptoms and present them to me. This will help you to not miss any serious or life-threatening presentations. Alternately, the suggestion for improvement might be in the form of demonstrating a physical exam skill missed or providing a journal article to deepen the learner's understanding on a particular topic. Your feedback using this tool should be brief and to the point. However, as you can see, you will have accomplished many good student-centric outcomes in the process that the student and you can continue to build on. Okay, so for our first interactive case, we're going to role play a patient case presentation, and I've got Jonathan here who's going to play the role of a medical student.
Hi, Dr. H.
Hi, Jonathan. Who did you see?
I just saw Miss Wallace. She's a 57-year-old Caucasian female with a history of hypertension who presents for a refill on her medication. With regard to her high blood pressure, she states that she is taking lisinopril 40 milligrams daily. She has a home arm blood pressure cuff and she is checking twice a week just like you told her to do. She brought in her blood pressure log and her blood pressures range from 105 to 122 systolic and between 60 and 78 diastolic. She denies any adverse effects on the medication. She's been walking for 30 minutes every day for the last 3 months and following the DASH diet you prescribed for her. She thinks that she has lost around 15 pounds. She's noticed that her blood pressure has been a lot lower in the last month and is wondering if it's because she's made changes in her exercise and eating to help her lose weight. On physical exam, the vitals are within normal limits. Her BMI has dropped down to 29. So for my assessment, as far as the high blood pressure, she just needs refills on her lisinopril, and I thought we can go do her exam together.
Okay, now based on that presentation and using the 1-minute preceptor tool, let's test your knowledge retention. The best answer would be to ask the student his assessment. For example, how would you classify or characterize this patient's hypertension? A next question, such as, what criteria do you use to determine if a patient's blood pressure is well controlled or not, is an example of which of the following components of the 1-minute preceptor. The best answer, probing for supporting details, is number 2 on the 1-minute preceptor list. To reinforce what was done well, step 4 of the 1-minute preceptor, you would state something like, the best answer would be to share feedback of, I think it was excellent that you looked up relevant data in the EHR and also asked the patient questions to provide context for her health status. Lastly, to correct errors and/or make recommendations for improvement, which statement would be the most helpful? The best answer option consistent with the 1-minute preceptor model would be to state, I'll email you a link to the current JNCA guidelines. They state that for our patient, who is under 60 years old, the normal blood pressure cutoff is less than 140/90. If this patient were over 60, there is a more relaxed cutoff of 150/90. Okay, so to illustrate what it might sound like to use the 1-minute preceptor model to provide feedback to a student, imagine that a dialogue has taken place after a learner case presentation of a 3-year-old boy complaining of an earache. To get a commitment, I as the teacher might ask something like, so what do you think is going on?
I think he has an upper respiratory tract infection, probably an acute bacterial otitis media.
To probe for supporting evidence, I might say something like, oh, okay, so what led you to that conclusion?
Well, he has a history of repeated acute otitis media and currently has a fever and painful right ear. In addition, I believe his right ear is red and less mobile.
What would you like to do for him?
First, I would like you to confirm my findings. If you agree, then we should give him some antibiotics, as he doesn't have any allergies to medications and was successfully treated with amoxicillin in the past. I think amoxicillin is a reasonable choice.
So then I would teach a general principle, something like, it does sound like otitis media. The key features of otitis media in the history are upper respiratory tract symptoms followed by ear pain and increasing fever and irritability. He's also at risk as he has had prior episodes of acute otitis media. In the physical examination, I look for the appearance of the eardrum, including any erythema, opacification, and distortion of landmarks with bulging or retraction. Sometimes there will be purulent discharge at the external canal if the tympanic membrane has perforated. This child would seem to fit these criteria. With the lack of allergies, amoxicillin is a logical choice for an antibiotic. I'll be glad to confirm your ear examination findings. Let's go and see the patient. And then finally, to reinforce what was done well, I might say something like, you did a really good job of putting together the history and exam findings to come up with the correct diagnosis. And finally, to correct errors and/or make recommendations for improvement, one example would be, I'd like you to read this article from the Cochrane Collaboration Database on acute otitis media. Not all patients who have acute otitis media meet criteria for antibiotic therapy. So why don't you review that article and we'll talk about it tomorrow. Here's another tool you might use, especially for novice learners, whether they be a student early in clinical training, a more experienced learner but new to a rotation, or a learner at any stage learning a new concept or skill. The tool is called Active Demonstrations. It is similar to bedside teaching, but with an intentional twist. Prior to seeing the patient with the learner, set up a learning goal such as, listen to my discussion with the patient regarding this abnormal lab test, or watch how I do this procedure. Let the learner know you will debrief with them after the patient interaction by stating, after we see the patient, I would like you to describe what you observed and what you learned. Then, based on the learner's answer and the accuracy of their perceptions, you can teach to their learning needs. For students who are observing or shadowing only, activated demonstrations is a powerful tool to keep the learner engaged and invested in the patient encounter. Another tool is called the 2-minute observation. For this, inform the patient and learner you will be observing in the background for teaching purposes only. You can then slip in and out of the exam room for a few minutes, observe the learner-patient interaction, and provide feedback to the learner when they come out to present. Although a valuable tool for novice learners, don't hesitate to use this tool for more advanced students and residents as well. As experience and autonomy grow, there tends to be a directly proportionate decrease in observation and feedback, which can allow an error or suboptimal approach to persist. It's impossible to know for certain if a learner is competent at an exam skill by the presentation alone, so the 2-minute observer tool can be added to strengthen your ability to teach to learner needs. Our next set of tools carry some fun names. Aunt Minnie is typically used for more advanced learners and focuses on pattern recognition. The name comes from the concept that if you see a woman across the street and she looks like your Aunt Minnie and she walks like your Aunt Minnie, but you can't see her face, it's a safe bet that the woman is indeed your Aunt Minnie. The sequence is this. The learner sees the patient and presents the history and physical exam. The presentation only contains the main complaint. For example, Johnny is a 2-month-old infant male with a temperature of 40 degrees Celsius who appears ill and is lying listlessly in his mother's arms. And the learner's presumptive diagnosis. This may be a virus, but I think we should rule out bacteremia and meningitis. This should take less than 30 seconds. Secondly, the learner begins the clinical note while the teacher sees the patient, diagnoses the problem, and creates a management plan. The teacher then discusses the case with the learner, and the teacher reviews and signs the medical encounter. Next, we have the SNAPS model, which is a student-controlled format. If choosing this model for advanced learners, let the student or resident know that you expect them to present in the SNAPS format, which stands for summarize, the brief history and physical, narrow the differential to 2 or 3 relevant possibilities, analyze the differential diagnosis in terms of what is more or less likely, probe. In this step, the student identifies their own uncertainties and queries the preceptor, plan management of the patient problems, and the student plans some self-directed learning. Another fun mnemonic is SPIT, which is a tool that can be mixed and matched with other tools, but is useful to help quickly create a useful differential diagnosis. The student is asked to come up with possible etiologies to explain history and physical findings that are serious, probable, interesting, and treatable. For example, for vision loss in an elderly patient, a serious or emergent cause might be acute angle closure glaucoma. If indicated by history and physical exam, a probable cause might be cataracts. An interesting cause might be primary ocular lymphoma, and treatable causes might include diabetic retinopathies, but not necessarily age-related macular degeneration. The mnemonic at least makes for an interesting structure for students to frame their differential diagnosis building upon, and it's quick to use, unlike some of the other differential diagnosis mnemonics, such as medicine or vindicate, which are tools better matched to situations with more time for discussion, such as morning report, noon conference, over lunch, etc. So now that we have a number of tools in our tool belt, let's do a quick review of how to choose them. Step 1 is to identify the needs of each individual learner by asking questions or by doing a 2-minute observation. In Step 2, we select a model for rapid teaching. And in Step 3, we provide feedback on performance by quickly commenting on strengths and making recommendations for improvement. Finally, don't forget about the tool of self-reflection at the end of a teaching session to help us as clinicians grow to be even better educators and masters at our craft. John Dewey perhaps said it best, We do not learn from experience, we learn from reflecting on experience. And of course, there are great tools to help you do this. The W3 model is effective and efficient. All you have to do is ask yourself, what worked well? What didn't work well? What could have been done differently? Or what can I do better in the future? And then what do I need to know more about? What are the steps to get there? Stepping back to the 40,000-foot level, another tool for reflecting on effectiveness for achieving your goals as a clinical educator is SWOT analysis, which we've borrowed from business and leadership literature. In this approach, it is helpful to write out what your strengths are, weaknesses, opportunities to achieve your goals, and threats to your professional goals as an educator. The next step in this reflection is to address each. Specifically focusing on threats by way of example, we might note common pressures on productivity, our schedules, and time limits built into our day. Once identified, there is opportunity to explore possibilities that are customized to your unique patient care setting. Only you and your team know what those needs and opportunities are, but let's take a look at one example in the outpatient clinic setting. So in this example, we'll zoom in on the first hour of a clinic schedule, in which patients are scheduled every 20 minutes. Let's say you've gone through ahead of time and identified which patients would be most amenable to seeing a student and providing valuable learning experiences. As you might imagine, it might be difficult to have a learner come out of Mr. Lopez's room to present, only to have to wait until you've finished seeing the next patient. There are often mismatches in timing in a traditional schedule such as this, and no protected time for teaching. And patients can end up waiting longer than usual, which can affect patient satisfaction. While there are creative ways to work within a traditional schedule, let's look at an example of how a schedule might be flexed instead. In this example, every other slot is double booked, providing a patient for both preceptor and learner to see simultaneously, followed by a time for the learner to present and the learner attending team to see the student's patient together. If you notice, the same number of patients are scheduled per hour, so there is no loss of productivity, but now the schedule is much more fit to the academic physician's needs. There are many variations on this theme possible and unique flexibility available in other settings such as the ED, where patients are not scheduled but rather triaged and roomed at different times. For hospital teaching specifically, the reference at the bottom of this slide is an invaluable resource. Our time is coming to a close, but I hope you've gained some valuable tools and logistical approaches to help support your teaching goals. Additional resources and references include the following. Your reading assignment and discussion board prompts can be found on Blackboard. Thank you very much for your participation and time. Please feel welcome to contact me with any comments or questions. See you soon.